fine. Oh, you got me, partner.
Okay, so this goes over here.
Ah.
Bring some instruments, please. I don't need a break, I just need. You got time for that now? Yeah, okay. So, bowel resection. So we know who gets, what we're looking for when we go in here, what it causes, adhesions, diverticulitis, diverticulosis, any polyps, any kind of tumors,
Cancer.
all those things. Okay, so what is our pre-op? How do we prep them?
From nipple to mid-thigh.
Nipple to mid-thigh. Okay, what else you need to do pre-op? Foley catheter, great. What else?
Need to set up your
Somebody said SCDs once on their paper, I think, right? Sequential compression devices.
yes.
Since the patient's gonna be laying in this state for at least maybe 2 hours, we need to make sure we get return of venous flow. So SCDs, belly open, right?
Mm-hmm.
So we need to make sure that these people stay warm. So we put a bear hugger up top, maybe even a bear hugger down the bottom where we can keep them at least somewhat of a core temperature. That's important. Okay, getting ready to do bowel surgery. NG tube is put into the stomach by anesthesia, sucking out all the contents. Because we need to make sure that goes down and out of the way. Anything else we need to do pre-op? Anybody can?
Do we get the NG tube or does the anesthesia get it?
It's usually pulled on your card.
Okay.
It's on your preference card normally, but anesthesia puts it down. Make a midline incision. Midline incision. What's my landmark once I cut the skin? Who's that is?
Belly button?
What's my landmark? Linea.
Alba.
Thank you. Linea alba. It's going to be my white line. It's going to mark the very center between those muscles, because I don't want to cut muscle, because muscle is hard to repair. Let me take this out. This. Put my bowel flora in. Use that first. Okay. What else can I use besides the bowel flora? Never use a Conroe Sullivan? Why would you? When would you use a Conroe Sullivan?
TH.
Yeah, that's pretty much all the time you'll see it. Other people don't even know how to use it. Usually once you get down in here, you've identified the colon. How do I know I have the large colon? How do I know it?
Hofstra and Taenia coli.
Ligament. What's it called?
It's the ligament.
The Taenia coli?
Yep.
On it.
Yeah. Well, you got Hofstra. You got what else?
Taenia coli, you got,
You have epoic fat.
yes.
Right. Big globs of fat hanging off of it.
What are you grabbing on?
I'm just grabbing it.
Okay.
And when you grab it, you want to grab it with something that's pretty atraumatic, like a Babcock. Okay. Then we usually dissect down. Take a Bowie and take a, yeah. And usually the dissecting down is usually just enough to make a spot, use that, so that you can clamp those vessels on some of the tributaries that come off the colic. And usually what we're doing is clamp, cut, tie, so that we can free up a space. it's not, you can't do that for this case. And usually, you can put that down, hold that one. And then make it hard. And right forward. And this is that's the song you play in general surgery. Clamp, clamp,
Cut.
cut, cut. Especially when you're doing bowel resection. Okay. So, we'll assume that's already done. What we've done now is we've identified our intestine. So our lesion is there. See blue, you see green. This is white. Okay. Whenever you see a white load in any staple, it's for vascularity.
Okay.
So whenever you're going over a vessel or some kind of vascular structure, you need to make sure you use white. You wouldn't necessarily use white for this. It's bowel. This is standard for bowel.
Blue.
Blue. When you have thick bowel, because people are different, you use the green. Green is for thick, blue is standard, white is vascular.
And what are these called?
These are GIA staples.